my right hand there?
Right here. Excellent. Well, it's an honor to speak at this event and to follow Tayana, who didn't talk about the work that we're collaborating on, but she's a tough act to follow. It actually it relates to some of the work that we're doing in terms of battery management and wireless health. So, again, I'm going to talk about mobile and some of the work that we're doing in our laboratory here at Cal IT. Which do I push? Is it this one?
That's the wrong one. The other changer there.
This one.
No, I had the right one.
This one right here.
The left and right there.
Yeah.
Hit the right button.
I am.
If you want, just pull up the keyboard there, and you can use that.
Here we go.
Battery management. We need.
Yeah,
Where's
yeah,
Tayana
that's
when we need her?
So just
Okay, I'll use
should be
this.
just the keys.
Yeah, I'll use this.
Yeah, that should do it.
Okay.
The arrow keys will.
Yeah, I just need to be able to see it. Okay, again. Start again here. Okay, what is the Center for Wireless and Population Health Systems? We do research in a variety of areas here. You can see the types of problems that we've addressed over the last few years on wireless, clinical, and home-based technologies to measure and improve behaviors and hopefully get better health outcomes. So we focus a lot on sensing and intervention, and that's going to be one of the sort of the theme of what I'll talk about. We have a variety of collaborators. We fit very, very nicely within Cal IT because we have collaborators from the School of Medicine, the School of Engineering, San Diego Supercomputer Center, James Fowler, who you heard speak earlier today in political science, and now also with the School of Medicine, and collaborators across the way over with SDSU in the area of psychology and exercise and nutrition sciences, and a wonderful group of graduate students, undergrads, and staff as well. So the point of view of our research, and this is very, very important to sort of state, is that we have a point of view. We actually are looking at issues related to genetic and biological factors, to behavioral and social factors, and to the environmental and ecological factors that influence them. And this is the exciting thing to us about wireless technologies, is that they're one of the few things that really can cut across these, we think, and will help some of this. The seams become sort of seamless between the influences on health, and these all influence each other. This is multidimensional and multi-level, and one needs to acknowledge this when you're thinking about trying to create systems to make a difference. So we acknowledge very much the notion of system sciences and biological and medical sciences, the behavioral and social sciences, and the environment and policy and population sciences as well. My particular background is both clinical medicine and in preventive medicine and public health, and that frames a lot of the work that we focus on. So we work hand in hand with the engineers that you've heard talk today and other scientists to develop technologies that influence these. So nanotechnology, the kinds of things, drug delivery technologies, all of what is being built out there needs to connect through the types of technologies that I'll be talking about to body area networks and mobile phones and go back into databases from via the mobile phone and up into the cloud. And location-aware systems and other things. So there's a broad sort of systems approach to what it is that one needs to do in this area. So I'm going to talk about five different projects that we're working on in this area of sensing and intervention. The first couple will focus on sensing and then move to the intervention. First is PALMS. This is a project called Physical Activity Location Measurement System. There's probably no behavior more important to health but less well understood than physical activity. We just sort of take it for granted and tell people as a clinician to go out to walk or come up with public health guidelines, but we really don't understand very much about how it relates to health. So this is a project that is aimed at getting a better understanding of physical activity where it occurs in time and in space. And it's part of a big family of projects called the Gene Environment Initiative, about $80 million worth of projects that were funded in fiscal year 07 by NIH. And ours is in the diet and physical activity portfolio, but you can see a variety of other kinds of sensors and devices were funded to be developed over time to then be put into place in prospective studies looking at relationships between genes and the environment. So our system is aimed at researchers, and it's effectively aiming to allow researchers to instrument individuals with physical activity and heart rate devices and other sorts of things, to collect those data, to bring the data into an infrastructure that can allow researchers to visualize it, and can allow individuals to also reanalyze the data. There's a big move now at NIH and among other sort of big science to get increasing amounts of sort of squeeze the data that you have and have other people use it, but it's a non-trivial matter to actually find ways to make that happen. So our infrastructure is being built to support this. The devices we're using are a variety of devices. When we originally proposed this project, we were talking about using one or two, but this whole ecosystem of devices, you saw Larry Smarr this morning wearing his body bug and other things. There are lots of devices that people are building. So we're now device agnostic, and we're very interested in capturing a variety of data from a variety of the different devices in both the activity side of the equation and the GPS side of the equation. And GPS is longitude, so it tells you effectively where people are, but also, importantly, time. And so it allows second by second by second capture and alignment of the other data that sensors might come up with. So what kinds of research questions can be asked by collecting these data in better ways? So are places where people spend lots of time associated with unhealthy behaviors, snacking, or toxic exposure. So how do you know? How did we know before we develop a system like this how long people spend in certain places? Research question, which neighborhood features support the most physical activity? It's critically important. If you want to be active, you have to be able to be active someplace. You know, that's the dependencies between those are very important, and there's a whole area of research now called active living research and building neighborhoods and locations where people can be active. Which locations entail prolonged periods of sitting? What are sort of sedentary hotspots? I mean, where are people spending lots of time? The world of sedentary behavior is now being understood in very different ways from physical activity as far as its risks to your bone health, to metabolic health, to a variety of things. So the technologies in PALMS are helping us understand this and helping researchers visualize these data on a dashboard at both an individual and a population basis. And we've engendered a fair amount of interest. We now have PALMS users in Copenhagen and Perth, throughout the U.S. Lots of excitement, and this actually is a one-of-a-kind project in this Gene Environment Initiative, and was sort of finally recognized at that by the folks at NIEHS at our most recent visit. So we're really excited about this project, and want more information on this, I can chat with you. Now another project, PsyCor. This is a cyber infrastructure for comparative effectiveness research in cancer. This was one of the Grand Opportunity Grants that was funded by the NIH and the ARA Economic Stimulation Plan. And the aim here is to improve the ways in which we capture data from people in clinical trials for cancer. An increasing amount of cancer care is actually happening now in the context of clinical research rather than known drugs that might be used, or known radiation treatments or other things. So what is this system? This is a collaboration, I should mention, with MD Anderson in Houston, the biggest cancer center in the world, and here at Cal IT too. And so what we're building is this architecture that at its core has the sort of thing that you heard Dr. Kruger talk about a little earlier, this sort of rich services and sort of services-oriented architecture base. But the action for our particular group is in the right upper quadrant of this picture. It's this notion of capturing data from individuals at home in between the visits that they might be making for their cancer care. And it's mind-boggling to think that we don't do this now. We send people home in between their treatments, and we wait until they come back in and ask them how they did. Well, we have the ability to instrument them. We actually have the ability to collect data in these individuals in between the visits and get an understanding of what are now called patient-reported outcomes, the kinds of things that are really very important. So what are we including in this? Weight, blood pressure, accelerometer, to get a sense of how active they are. Are they going home and just being inert, or are they actually being active and getting around? Pulse oximeter, GPS device, and devices to measure heart rate and movement and other things. And we have other things that sort of in the works that we're planning to develop for this. And the two use cases that we're working on will be colorectal cancer, a very common cancer that again, right now we're not collecting the kind of data in between the treatment visits that are important. And a very interesting one, head and neck cancer, a relatively, not as common as colorectal cancer, but one that has profound implications for quality of life, for ability to swallow, to consume liquids. And so in this, we're actually developing a video capture of how people do the exercises that they're supposed to do, that they need to do in between the visits to ensure that they're recovering from their head and neck cancer treatment. So this is the infrastructure for this, that again built after the fashion of what Dr. Kruger is talking about. And again, a non-trivial process to do this in a way that scales, that allows other researchers to use the data. And our vision for this, when we begin to roll this out now, will be to partner with our cancer center here, with MD Anderson. One of our colleagues has just moved to the cancer center at the University of Alabama, very heavily high health disparities community. And so the vision is that we'll be able to improve this sort of research across a broad range of the population. So from sensing to intervention, how do we take the data that we get and actually make a difference in terms of the care of individuals? And this concept of persuasive technologies has really gained traction over the last few years. And the way we look at it is we think that this is effectively in this mix of what we know about health-related data, what we can apply in the area of wireless technologies that can be with you all of the time and follow you, and then persuasive design, all of the things that can be used to sort of prompt and monitor and encourage individuals to change what it is that might be problematic for them. So I'm going to go over a couple of projects that we're working on here. MDiet is a randomized clinical trial to evaluate the use of just simple text messages. Can we use the 140-character message to make a difference if we send these messages out to folks and ask for responses? So this is a study where we structured our messages around what we knew would be useful as far as tips, questions, graphs, etc. We also included in this intervention little pictures, so the phones that these individuals used could accept picture messages as well, including a feedback to them about how their weight was doing over the time of the intervention. We personalized the messages. A lot of the literature in the area of text messaging now that's coming out in health is just simple pinging messages, just a simple sort of standard message that isn't tailored to the particular user. We really said, no, we want to tailor this to the person, their social supporter. We want to tailor it to where they shop. Ideally, tailor it to more things than that. The behaviors that we know that they do. Do they snack at bedtime, or do they do other things that they shouldn't be doing? So we developed this. We developed rule-based dialogues where we could send a message, get a message back, send another message, get a message back, and use this in the context of understanding and dialoguing with this person. So fairly sophisticated use of texting, although I suppose now no more sophisticated than the typical 13-year-old does on their phones. But when we started the intervention, we had 3,000 messages, 1,500 different intervention rules, set it up in a way that this would work over a 4-month period of time. We enrolled about 60 adults into this, overweight, randomized them to the treatment condition or the experimental condition. And long story short, we ended up with effects. It was a pilot study, so we weren't quite sure we would even see any effects on this, but we did see in both men and women a measurably important reduction in weight between the two groups, about 4.25 pounds. This is very similar to the other kinds of things that are seen in other sorts of interventions. And so this is the first report in literature of a randomized trial in this area. We now have a larger study that we're moving forward to follow people for a year. We're going to be doing it in both English and Spanish language, and also embedding a lot more sophisticated logic in the intervention so that we can do a deeper dive into what it is that we think might work in terms of grabbing people and persuading them to make a change. The next project, intervention project, SMART, social mobile approach. This is where we're bringing mobile and social factors together into an intervention to see if we can make a difference. And our target is weight gain in young adults. This is a very important problem. People graduate from high school, the military or whatever, they're often normal weight and have a baby or two or whatever, and bingo, they've gained weight. There's hardly anything known about what we can do to prevent that or address that in early adulthood. Yet we know it leads to all kinds of premature morbidity and mortality. So I put this slide in here. This picture, James showed this morning. This is going to be a classic. I predict 100 years from now, people will go back to this particular New England Journal article and say this is the first time this sort of thing was characterized. So this is the 2007 article characterizing spread of obesity in social networks. So James is a collaborator on our project, and he's helping us think through how we use that knowledge and deploy it empirically. Really think about using Facebook, using a social network, and pushing here and hopefully making a difference there in terms of the behaviors of friends of friends, and others, and your friends and friends of friends actually making a difference in your behavior. So we're developing an intervention that includes what we hope will be a seamless and powerful thing across web, mobile, and Facebook. Mobile will include both smartphone apps, and if you don't have a smartphone, we'll be using SMS messages. And we are calling this 3-2-Me enabled, I think, apps is latest term for this, and that is that we envision, because young people have a short attention span, developing a successive series of applications over time as this intervention rolls out, because we have to follow folks for a 2-year period of time. We have to go for 2-year outcomes. We're going to be developing Facebook apps as well. We've got partners at Stanford University that are helping us with this. And it's going to use state-of-the-science behavioral theory and principles. We have we think, some of the best psychologists and others helping us think through what the core intervention is. And there really is a science. It's a slowly evolving science, but it's a science in this area of behavior change. So we're building in core behavioral strategies, a variety of things that we sort of method in the madness of what it is that we're developing here. And as I mentioned, we've got to follow these folks for a 2-year period of time. 2 years is almost a lifetime in a weight-related study. A lot of people declare victory after 4 months or 6 months or whatever and say, yeah, they lost weight and no problem. But our primary outcomes will be at 2 years. And so we've got a pretty intensive approach that we're going to be using for this. We'll be randomizing almost 400 individuals to treatment and control. And we've got partners at both Stanford and Nokia. And we'll be using, again, Facebook as a platform. So the last project that I'll talk about here is CitySense. This is a project that's addressing the issue of environmental quality. And the target issue here is air quality. You can recognize that picture, anybody who spends time on the freeways in Southern California. San Diego County has 4,000 square miles. We've got 3.1 million residents. And we have 5 EPA sensors, 5 stationary sensors throughout the entire county to model and understand what the air quality is in your neighborhood, and your neighborhood, and your neighborhood. One might think that that's imprecise. This relates to a lot of what we heard before, the whole notion of the movement of better sensing so that the granularity is important for you and can be personalized for you. So this is the vision, and Bill Griswold in engineering is the PI. I'm fortunate enough to work on this. Tayana Rosing is working with him, Ingolf and others. And the vision here is to imagine you can add to those 5 stationary sensors, and they're not going to go away, data that are collected in free-living individuals as they go about carrying their mobile phones with a sensor that Bluetooth communicates, or radio communicates to the phone, and allows individuals to get information about what's going on in their microclimate, in their micro area. And it's a non-trivial issue to think about this, but Fred and I, or my lead systems person, and I were down at the health department yesterday, showed them this slide, and they wanted this tomorrow. They wanted this Wednesday when they're going to do the controlled burn explosion of the home up in, it's like, how are we going to know what's going on there? Can we use this? It says, no, it's not quite ready yet for that, but that sort of thing. Imagine something happens, a toxic event of some kind, and you happen to have one of those phones, and you also happen to have one of the sensors, or you could drive by and pick it up because your particular neighborhood is going to be affected. So we've been working, again, with this wonderful group of engineering students and others in the CitySense sensor board for nitrogen oxides, carbon monoxide, temperature, pressure, humidity, a variety of other things. This is a scalable board with a radio in it that effectively allows it to connect, and this is just the first version, the sort of the beta version of the Android phone platform that's pulling the data in and giving people real-time feedback. But it's also shipping it upstream into the cloud, into the database, to allow anyone to look at it potentially. It's just a really exciting project. I think within this next week to 10 days, going to be starting a study with 15 cyclists in different areas of San Diego to get a sense of what's happening. So this is the sort of summary. Health systems change effectively coming from a variety of things that relate to sensing and integrating this with social and mobile technologies and other things and using it to intervene. The exciting thing here is really trying to make a difference. You heard Dr. Senya talk this morning about the train wreck of medical expenses that we simply cannot afford. We've got to find disruptive strategies to make a difference so that we don't spend $4 or $5 trillion a year on healthcare as we are now predicted to be doing within a very short few years. So that's it. Willing to take questions.